I'm going to run through very quickly through a case where I was an expert for the hospital. The defence side, or sorry, the patient side, was booked by another very well-known obstetric anaesthetist, whose name I won't mention. But I reckon what they were talking about was really a counsel of perfection, the absolute perfect treatment. And I want you to remember everything that Colleen said in the last thing, particularly with, was it a breach of duty? Did that breach of duty cause the problem? If what the patient's expert claimed should have happened, if that had happened, would that actually have made any difference to the outcome? So I want you to remember all those things. So this is a 19-year-old, Rabbit 2, Para 3, it's just before midnight. And the anaesthetist gets a request for an emergency cesarean section. First, the anaesthetist knows about this particular patient. Goes to see the patient. Oh, a little bit about the history of the anaesthetist, because this actually was important as well. SHO, 4 years experience in India before coming to the UK, done at least 25 GAs, and after a short clinical attachment is appointed as an SHO, and this actual case took place near the end of the 3-month block as anaesthetist, and it had been deemed to be competent. So this is the history he gets from the patient. Shortly before coming into the hospital, she's been in the pub, had some sandwiches, and a couple of half pints, and has a rupture of the membranes. Admitted at 22:40, history comes out. She's declined dexamethasone, and it's thought to be a transverse lie, according to the midwife. Bit more history, 102 kilograms, that's a BMI of nearly 38, and a few days ago she was 120 kilograms. I don't know if a BMI at the end of pregnancy counts, but anyway, it's there. Previous obstetric history. 1998, refused all investigations in the antenatal period, claimed she was needle phobic. But interestingly, when she got into labour, she had an IV and she had an epidural for pain relief. And the SHO used that epidural for caesarean section. A couple of years later, she comes back, and this time she's for an elective section. And a consultant anaesthetist had tremendous difficulties with her, trying to get a needle into her. Could not persuade her to have a regional anaesthetic. She insisted if she was going to have a GA, if anything. And eventually, a needle was put in, and an SHO gave the general anaesthetic quite uneventfully, once the needle was in. In the current pregnancy, once again, she's refused all investigations and claims needle phobia. And so far, she's also refusing any obstetric intervention, including further physical examination by the obstetric registrar, so the consultant is called in. Patient refuses to allow him to examine her, and eventually the patient consented to the obstetric SPR to perform an ultrasound. Note, not the consultant. And the transverse lie was confirmed. But she's refusing a caesarean section. She's basically told the obstetricians, no, I'm not having a caesarean section. So the SHO records a few more bits and pieces, all these sort of things. Explains the risks of aspiration, had some local anaesthetic on her hand, etc. However, she's currently refusing a caesarean section, either with regional anaesthetic or general anaesthetic. But she is given some sodium citrate and ranitidine, which she takes. So, as a resident anaesthetist, what are you going to do now? As a consultant at home in bed, what do you want your SHO to do now? Wake the consultant and tell them, well, there might be a caesarean section if she eventually agrees to it. Soon, sometime, never. Wait and see the outcome of the obstetric discussions and see if she eventually does agree to have a caesarean section. And anyway, while the consultant obstetrician's having a heart-to-heart with her, the anaesthetist has to go off and do something else. Oh, he did contact his own consultant as well and just explained to him what was going on. And the consultant, aware of the previous general anaesthetic given by an SHO, once the IV cannula was in, said, fine, get the cannula in and give her another GA. And the SHO went off to do an epidural on somebody else. Eventually, 1:20, she agreed to have a caesarean section, went to the anaesthetic room, but now says she's not having an anaesthetic. Refusing IV access, abusive, violent, using Entonox for the pain. Uncle Tom Cobley and all are in there trying to persuade her to have this IV put in. What are you going to do now as the SHO? Call the consultant again? Tell them you can't get in, she won't allow you to put an IV in? And what are you going to tell the consultant? She won't let me put an IV in. Is this the high risk situation? No IV, no GA, no risk. Should the consultant come in? Who knows? Anyway, Anaesthesis gets called away again to assess somebody else, and as he comes back, the paediatric registrar with a small envelope.
Oh dear. Thanks very much.
Problem solved. You're going to phone your consultant now? You've got the IV in, you've been given your instructions, IV in, give her a GA. Okay? SHO, I think, quite correctly, decides to carry on. Change the Ventolin once the patient's asleep. Now, it's a long time since there's sodium citrate, and so she's due another dose. It's more than 2 hours since she had it. But she's now refusing further sodium citrate. What are you going to do now? Call your consultant? Please, sir, please, ma'am, she's not taking the sodium citrate. Should the consultant come in and pour it down the throat? Should the anaesthetist delay things until the consultant can come in? What can the consultant do anyway? SHO decides to continue anyway. Now she's refusing pre-oxygenation. Never mind 3 minutes, she's not having any of it. Swearing at the SHO. What's the SHO going to do now? Call the consultant again? Tell him what? Patient won't allow pre-oxygenation. Should we delay the anaesthetic until she has her pre-oxygenation? What's the consultant going to do? SHO continues with the induction. Thiol sucks cricoid pressure. Tries to assess the jaw after a short time. Not relaxed enough. Waits longer. A sudden noise. And a quick laryngoscopy shows profuse secretions in the oropharynx. This is what happens next. Tubes put down, suctioned, endotracheal tube, taken out, option bagging, electromechanical dissociation, pulse becomes feeble, some compressions given, atropines given, ephedrines given, trash teams called, consultant anaesthetist called. LMA's inserted, bagging's easy, saturations come up, patient turned to lateral, woke up, spat out the LMA, consultant arrives, and there still needs a caesarean section, so what does the consultant do? Well, he gives her a spinal anaesthetic successfully, but he didn't get any patient consent. She's just there lying on the side, half groggy and not having almost died. But anyway, spinal's put in, and they carry on with the caesarean section. She's quite stable throughout surgery. Transferred to ITU. She's alert, orientated, but she needs high oxygen, decreased air entry, refusing blood gases, all blood tests, all abdominal examinations. The consultant anaesthetist, frankly in ITU, was a frank discussion with her, who explains all this sort of stuff, and she finally accepts that she'll have a bit of oxygen, she'll have the TED stockings put on, and surprisingly, she agrees to have subcutaneous heparin. But she's still refusing all blood samples and abdominal examination. She gets worse, refusing tracheostomy. She has continuous positive airway pressure, still refusing tracheostomy, but eventually is persuaded to have a general anaesthetic for one. And the consultant, ITU specialist, induces general anaesthesia. No cricoid pressure. Vomits again, aspirates, puts an LMA in this time. Not quite sure why, but never mind. And this consultant anaesthetist records at the end of the operation, get a quick laryngoscopy for a nasogastric tube, and he reckons this was a grade 1 view. To me, this is this consultant anaesthetist covering his backside because he knows he's cocked it up. And he's already trying to pass the blame onto the previous SHO. Anyway, patient dies, unfortunately. And it was claimed this was an inexperienced SHO with only 1 month's experience of obstetric anaesthesia and should not have been doing such a case. True or false? This is rubbish. 4 years of anaesthetic experience, probably more obstetric general anaesthetics than I've got after, I don't know, 30 years as a consultant. And at the end of the 3-month block of obstetric anaesthesia and deemed to be competent. Come on, go again. Claimed the consultant anaesthetist should have come in as this was a high-risk case. How many consultants are here? Do you think you should have come in for this case if the SHO phones you at midnight and said, well, she's refusing a caesarean section?
Well, I do actually, yeah.
That's one.
Yeah, I would want to come in too to share the pain.
I wouldn't have slept after that first call anyway. I actually disagree with the SHO. His experience, yes, he's experienced a routine, but his most is to do with the first time.
Okay, mixed opinions. That's what I would argue. Refusing to have a caesarean section. Previous uneventful general anaesthetic by an SHO. Consultant should have come in, blah, 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 and she should have had a spinal, as in fact occurred. But in the previous caesarean section, a consultant could not persuade her to have an epidural or a spinal or anything. So I don't think that stands. And the consultant was not going to persuade her to have a regional anaesthetic this time. She had already told the obstetric consultant where to go. And the epidural in her first labour was for pain, and pain is a very good persuader. SHO was inept. Failed intubation shouldn't have happened. Now, be that as it may, this was not a failed intubation that caused the vomiting and aspiration. The vomiting and aspiration in this case happened before the intubation attempt. Okay? So even if a consultant had come in, who's going to give the anaesthetic? How many of you would come in and actually give the anaesthetic? I wouldn't. I would stand back. This is an SHO who needs the experience. So this SHO is going to give the anaesthetic. Admittedly, you'll be standing beside them. It's SHO, sorry. Anyway, the regurgitation happened before the intubation. And even if the consultant had given the anaesthetic, she would still have regurgitated. There were no allegations made against the ITU consultant, but this, to me, is the biggest mess in the whole thing. With a history of failed intubation, was it reasonable to use an LMA? Should tripod pressure have been used? Well, I reckon it should have been. And although this aspiration may not have made any difference to the final outcome, to me, this is the coup de grace. This is the thing. But there were no allegations made against the ITU consultant. The settlement was agreed out of court because both sides felt vulnerable. And we've already had things on both sides. The main issue really was, should a consultant have come in? Okay, even if those of you who say the consultant should have come in, would that have made any difference? And I would argue it would not have made one whit of difference. Did this girl really have needle phobia? You discussed a case with my wife, who's a secondary school teacher, come across lots of teenage girls like this. This girl's mother and her best friend, she just said she was bloody minded, and if she says she's not going to do something, she's not going to do something, and there's nothing you will do to change her mind. And I think this is a girl who's got away with this sort of behaviour all her life, and unfortunately, this time came unstuck. Thank you.